Good evening and welcome to DeBakey CV Live. My name is Marvin Atkins. I'm one of the cardiac and vascular surgeons here at Houston Methodist Hospital, and I'd like to thank everyone for joining us this evening to continue our discussion regarding aortic dissection. Tonight we're going to tackle some of the newer aspects of type B aortic dissection and some of the nuances associated with that. This evening I'm joined by my esteemed colleague here in person in the studios, Dr. Thomas MacGillivray. And then remotely, we may be joined by one of our vascular surgery partners, Dr. Bavare. He's got some family issue, childcare stuff going on, so we're hoping that Charo is able to join us and contribute to this lively discussion as well. For our audience members out there, if you have any questions, we'd love for you to join and pose some questions to us. A couple different options. One is to join by the web. You can go to pollev.com and enter DeBakey, and then once it comes up, you can then respond with questions. Or you could join by text and go ahead and text the text DeBakey, D-E-B-A-K-E-Y, to the telephone number 37607. And you can also texting your messages, and along the way we'll get to your thoughts as well. So Tom, thank you very much for joining us this evening.
Marvin, thanks for having me.
Great
to see you.
Yeah, great to see you. So tonight we're going to discuss a little bit about type B aortic dissection. And so some of the newer things that have come out regarding type B is some new reporting standards. And so this is a update from March of 2020 this year, published jointly in both the Journal of Vascular Surgery and the Annals of Thoracic Surgery, is the SVS-STS reporting standards document. And so, it basically goes into some of the newer highlights here of what they're requesting physicians to go ahead and when they're reporting on type B dissection, so that we're all speaking the same language. So when we talk about research, when we talk about patient care, we can compare apples and apples and oranges and oranges. And so first, let's talk about the historic classification of type B aortic dissection. Back in 1965 at this institution, Dr. DeBakey came up with the classic DeBakey classification for type B dissection. So type A involves type 1 and type 2 of the ascending aorta, but then he classified distal dissections emanating distal to the left subclavian artery into 3A or 3B, whether they went above and or below the diaphragm. I believe it was in the 1980s that the Stanford classification came out to help simplify this, basically helping it divide it into folks that you needed to operate on emergently or patients that you could manage non-operatively. And again, that was kind of divided into type A proximal dissections and type B distal dissections. Over time, that's served us well, but it definitely has some specific drawbacks. So there are indications and times when this classification system or either classification system really doesn't help us. So one of those would be in the patient, what some people used to call the non-A, non-B, so somebody who has an arch dissection that's isolated to the arch or begins in the arch. It really doesn't give us any description of where the entry tear is, so we do see patients that have retrograde dissections with an entry tear starting off in the descending thoracic aorta, but then dissects all the way back around, and those patients are managed depending upon how far proximal that goes as a type A dissection. So it really doesn't give us an idea for the entry tear. And then also in patients that have had some type of either open or endovascular repair of the aorta, it doesn't really help us classify those patients either. And so this new classification system between the two different societies tried to solve some of those dilemmas. So here's a picture of a patient that has a entry tear in the transverse arch. Dissection begins there, does not extend into the ascending. So, is this a type A? Is this a type B? How would you manage this patient? And so this classification system hopefully will help us further define these patients. So I think it's useful for us to go through the classification system and how that's going to change here in the future. Well, any thoughts, Tom?
I think these are really important points, Marvin. And, I think that you can be a lumper or you can be a sorter. And I do think that the benefit of the Stanford classification is it lumps together type A, type B. And the benefit of that system is we all know that the natural history of type A aortic dissections are that those patients are at very high risk of having a life-threatening complication within a matter of hours or days that can be largely avoided by emergency operation. And what historically was true about type B aortic dissection was that open operations for type B dissections were associated with a pretty high operative mortality. And what they found was that medical therapy worked pretty well.
Correct.
And I think that was both good and bad, and that the presumption was, well, type B dissection is not a serious problem. It doesn't need an operation. Those patients are going to do okay. And I think that what we've learned is that type B aortic dissections represent a spectrum of disease. And depending upon the underlying condition of the aorta, where the entry tear is, the extent of the dissection, will all determine, or may help determine, what the natural history and the risk of that disease is.
Right.
And I think this new reporting system helps us sort those out and make better decisions for individual patients.
Great, great, important points. So just to start off with the new classification system, so it's really based upon the location of the entry tear, helps us decide whether it's needing an emergency operation or if it's something that initially could be managed medically. So it uses the Ishihara stages of the aorta there, the different zones, zone 0 being up towards the innominate, zone 1 including the left common carotid, zone 2 the left subclavian, and then it divides it into 3 at the isthmus, 4 in the proximal half of the descending thoracic aorta, type 5 in the lower half of the descending thoracic aorta, and then we go through the visceral segment, the renals, the infrarenal aorta, and down into the iliacs and the external iliacs. And so for a type A dissection, it needs to have an entry tear in zone 0. For type B, it has to have an entry tear somewhere beyond type 0, so any of the different zones thereafter. Many times we get patients that come in with a CT scan that is not very high quality, and so those patients will have an unidentified location to their entry tear. If that dissection does involve the ascending aorta, then we classify those also as a type A dissection, but in this setting you would call it I or D, unidentified entry tear involving zone 0. And so this new classification system also wants us, besides just type A, type B, it also wants us to have the proximal extent and distal extent of the dissection, which will help further classify and define these patients. And so I've got a couple sample patients here of their dissections. And so the first one, we see that the entry tear there is in zone 0 and extends all the way down to just above the aortic bifurcation into zone 9. And so this patient will be classified as a type A and then have a subclassification of 0,9. The second patient there, we can see that the entry tear is in zone 3, so just distal to the left subclavian artery, although the dissection does extend proximally into the transverse arch, just proximal to the innominate, and distally, again, it goes all the way down to zone 9. And so this patient would be a type B, 1,9 subclassification. The third patient there, again, has a dissection involving zone 2 at the level of the left subclavian artery. The dissection does extend proximally into the transverse arch and into the ascending aorta into zone 0, but distally down to 9. And so that patient, because the entry tear is beyond zone, at or beyond zone 1, it's classified as a type B dissection. And again, it would be classified 0,9, given the extent of the dissection. And so I think, at least the way we're classifying this, it's helping further define how we manage these patients that have this, previously termed non-A, non-B transverse arch dissection, and really managing them more in the terms of a type B dissection than emergent surgery. Thoughts on that, Tom?
Yeah, I mean, I do think this, as I said, it helps us sort out the extent and the initiating entry tear. One of the questions that always, at least in theory, you look at a scan and you can say, oh, this is the entry tear, but oftentimes we see people have more than one
entry
tear, and so how to accurately ascribe what's the entry tear, what are fenestrations that have resulted from the secondary either antegrade or retrograde extension of the dissection. And I think that this is a step forward. I'm not sure that this classification system much better than it has been, but I still think that it doesn't leave us with a totally answered problem.
Correct. I think in those situations you probably have to have a dynamic MR scan to be able to see the flow and direction of flow through the different entry tears and fenestrations, which obviously in many patients that's not their first imaging study.
Right.
Okay, great. All right, so again, the anatomic reporting of these aortic dissections is again based upon the location of the entry tear, A versus B, and then the proximal and distal extents. And we kind of went through some of the classifications there. And this is all in the Journal of Vascular Surgery in March of 2020 and the Annals of Thoracic Surgery in March of 2020 for your further perusal.
It's a great manuscript, I think.
Correct.
Yeah, it's chock-a-block full of information.
Yeah. That's right. So one of the other things that they tried to elucidate and sort out is the quote uncomplicated type B aortic dissection, because many of these patients when they come in and they don't have a rupture, they don't have a malperfusion, they get lumped into this uncomplicated type B aortic dissection category, and not all of those patients are the same. And so there definitely are some high risk features. And so one of the aims of this manuscript and this expert group of physicians that treat aortic dissection, they wanted to classify patients into a high-risk category, again, to help define those bad actors, those patients that are going to develop rapid expansion of their thoracic aorta, patients that are going to develop rupture, that have an increased risk of mortality. And so, obviously the patients that they're defining now as uncomplicated, these are patients that don't have a rupture, don't have a malperfusion, and they don't have any of the following high-risk features. And those high-risk features would be somebody that has refractory pain, patients that have refractory hypertension despite best attempts in the hospital at optimal medical management, anybody that's got a bloody pleural effusion especially, patients that have an initial aortic diameter including both the true lumen and the false lumen greater than 40 millimeters, any evidence of radiographic malperfusion. So this is not clinical malperfusion, but patients that have either a dissection flap that goes out statically into the branch vessels, or if they have a very, very narrow true lumen. So radiographic only malperfusion would be a high-risk feature. Patients that are having to come back in because of symptoms or for another reason, readmission patients, they're a high risk. If there's an entry tear on the lesser curve, that's also thought to be a bad actor. People have also put in, which they didn't have in the consensus statement, is an entry tear greater than a centimeter in diameter or in length. And then a false lumen diameter greater than 22 millimeters is also thought to be a bad actor. So these are all kind of high-risk features that when we're seeing these patients with type B aortic dissection, and we'll go into later some of the decision-making that goes around treating these patients or managing them conservatively in this lump category of what used to be uncomplicated type B aortic dissection, is how do we sort out those high-risk patients?
Yeah, and I think that, on that slide, I do think it's important to differentiate between malperfusion and malperfusion syndrome. And I think in the manuscript they consider malperfusion to be just radiographic malperfusion, and although concerning or worrisome, that's different from malperfusion syndrome, which actually is clinical ischemia in an organ system.
Correct.
And the other thing too is that do you get into sort of dynamic and static obstruction?
Of course.
Boy, I can't wait.
Trying to steal my thunder. All right.
I should have figured.
Of course. So the other thing that they kind of help define a little bit as well is located here in the bottom right-hand part of the screen. And so that's the timing of dissection. And so, there have been these kind of three categories of acute, subacute, and chronic that people have used over time. And they help to further define that a little bit more. Again, sorters and lumpers. So in the sorting category, they've now termed 4 different categories. So one of those is hyperacute, which is now defined as...
Traditionally, there was acute
and chronic,
which was 0 to 14 days.
Right.
And then there was chronic, sort of 14.0 something days
and beyond.
and infinity.
And then I guess over the last probably 5 years instead, et cetera, it kind of moved into this 3 categories of acute, subacute, and then chronic. And so now they've split it up further. So hyperacute is less than 24 hours. This acute phase is in the first 2 weeks of the dissection. Subacute is in the first 2 weeks to about 3 months. And then chronic, greater than 90 days. And so those are the standards that they're asking us now to report for type B aortic dissection. All right. One of the other things that hasn't been well defined is patients that have undergone TEVAR for dissection, the false lumen flow reporting. And so that's, it used to be that patients would have just basically 3 different categories. They either had a completely patent false lumen, meaning that there was still flow through the entry tear all the way down through the false lumen and then out multiple fenestrations, or they had partial false lumen thrombosis where typically distally in the false lumen, or if they've been treated with a TEVAR, sometimes proximally, you'll see thrombus in the false lumen, but then a good portion of the false lumen still has flow in it. And then the ideal category is the patient that completely thromboses their false lumen. Those are the patients that are going to remodel their aorta and essentially heal their aorta over time. And so those have been kind of the 3 categories that we've had, but now they've asked to define that a little bit further. And so
And partial thrombosis is actually
higher risk.
The higher risk, even higher risk for subsequent problems than a totally free-flowing false lumen flow.
Now, I remember there's a great New England paper, I don't have it referenced here, but where they went in and they measured pressures in the true lumen, false lumen in patients that had either a patent complete false lumen or a partial false lumen. And the end diastolic pressures were markedly elevated in the patients that had a partial thrombosis of their false lumen. And so that's thought to be another risk factor for somebody that's going to be a bad actor, is that partial false lumen thrombosis. So to help to further define some of the false lumen flow standards, they asked us to, they've split it now into 1A, which means that the patient has continued flow around an endograft going into the false lumen. That's a 1A endoleak. The 1B is what's termed proximal endoleak. Yeah. So the 1B is the stent graft-induced new entry tear sign that people have seen. So you put a stent graft in, you balloon the stent graft, or you may or may not balloon the stent graft, but just the mechanical forces of that stent graft cause a distal tear right at the distal portion of your stent graft. And so that's also thought to be a bad actor as well. You can have a type 2 leak from these patients, so that's typically somebody that has flow coming from their brachiocephalic vessels, or it could be coming backwards from either a bronchial or a thoracic intercostal artery. And then they've also termed this type R. So type R is patients that have false lumen flow coming from below. And so this can be from uncovered intercostals, from the visceral arteries, renal, lumbar, iliacs, or if they have a fenestration distally in the aorta that has not been treated. And so they've asked us to define these leaks as 1A, 1B, 2, and R. Things are getting complicated.
Type B and type A are starting to look, the lumping is not so bad.
That's right. All right, so now let's talk a little bit about aortic remodeling. So,
but I do think that, all kidding aside, I mean, the whole purpose of this classification system is to try and give us some insight as to those patients who you can predict may develop problems or more likely to develop problems that may benefit from intervention or earlier intervention, as opposed to those patients who might be well treated with optimal medical management. So it's in the old days, we used to just sort of wait and see what happened and try to react to a problem rather than be proactive about it. And I think this is an effort to get the information that will allow us to be proactive.
Sin of omission versus a sin of commission.
Exactly.
All right, so one of the other things that they asked us to define is aortic remodeling. And so in many manuscripts, when we're looking at especially stent graft repair of type B aortic dissection, one of the things they will report is either positive or negative aortic remodeling. So they really wanted to define that better. And so the term aortic remodeling really needs to account for the entire aorta, not just at the site of the TEVAR. So Many times we'll see patients where they get a thoracic endovascular repair. We'll see that that segment of the aorta will shrink down in size, but the distal segment of the aorta that's been left untreated can have negative or adverse remodeling. And so how do you really report that patient? And so what they've asked is to report positive aortic remodeling, means that you get false lumen reduction in both the max diameter or volume, and no growth in your total aortic diameter or volume anywhere throughout the aorta. Or you get true lumen expansion in both the max diameter or volume and no growth in the total aortic diameter or volume, or that the total aortic max diameter reduction with variable changes in the true and the false lumen. So the negative aspect of that would be negative aortic remodeling, which means that you have an opposite behavior. So either the true lumen or the false lumen is expanding somewhere throughout the aorta. And so rather than reporting on just in the thoracic aorta where a thoracic stent graft is, to go ahead and take the whole aorta into consideration. Makes sense?
Yeah.
All right, so let's start getting into good things. So one is, or bad things, I guess. So one of those is malperfusion. So we'll talk a little bit about the different types of malperfusion and treatments for those. So obviously malperfusion, mostly caused by severe compression of the true lumen by the false lumen. It's patients that have a higher pressure in their false lumen. It will cause the fragile septum to move over, compressing the true lumen. And usually when you're looking at a CT scan, as we all know, that it's typically that the true lumen is the smaller of the two. The usual anatomic pattern that we see is sometimes that the celiac, SMA, and right renal emanate off of the true lumen, left renal off of the false, but that's definitely not always the case, but many times that is the case. So two different types of malperfusion. So one is static and one is dynamic obstruction. So dynamic obstruction is really at the level of obstruction is at the level of the aorta. And so your septum is prolapsing into the vessel origins of either your visceral segment or your renals or your iliacs during systole. And that happens because with systole and the large entry tear, there's increased flow into that false lumen, and it pushes that, and essentially ball valve pushes over and covers the origins to your vessels. And so during systole, they're not getting the adequate perfusion that they need. And so dynamic obstruction allows us to treat things at the aortic level for this. So one of those is putting a TEVAR in. And so many times if we have a patient that has malperfusion syndrome, we'll go ahead and we'll stent graft the entry tear, which then shuts off flow going into that, hopefully decompressing their false lumen. And sometimes we have to extend that for a fair distance. Sometimes just a proximal 10 centimeter piece of a stent graft is not long enough.
So even take a step backwards. So even medical management can make a difference with malperfusion. That if you lower the blood pressure, because oftentimes these patients come in and because of the nature of the underlying nature of their comorbidities, but also with the differences in perfusion to their kidneys, they can be very hypertensive. And by giving anti-impulse therapy, you can change the dynamic between the true and false lumen and improve sometimes a malperfusion syndrome with medical management. So when you see a patient in the emergency room or in the ICU that has some malperfusion syndrome, while you're planning to do something from an interventional point of view, by optimizing them medically, you can oftentimes, or sometimes anyway, reverse that.
So definitely, we don't want to forget best medical therapy is the initial treatment for all of these patients. One scenario I'll kind of propose to you. So this was probably the most difficult patient that I encountered in my initial vascular practice before I went back into cardiac. And so this was a patient that came in with a type B aortic dissection. And all of a sudden, the entry tear went completely posteriorly and took out all of the intercostals. And she presented with paraplegia as the symptom, so chest pain and paraplegia. So in this patient, I put a lumbar drain in, and then I really struggled about what to do in terms of her blood pressure. Do I keep it up for her spinal cord? Do I keep it down for the dissection? And then I debated about what should I do in terms of, should I put a stent graft in and possibly cover more of her intercostals doing that, the extent and length of dissection. That was one that I really struggled with, and love to get your thoughts on that type of patient.
those are the kinds of patients that, in my opinion, I mean, I guess I don't know what the right answer to that is. I think that, certainly with spinal cord malperfusion, I think that putting in a spinal drain and trying to get their blood pressure up may help if it's a dynamic problem that's affecting their Aortic Dissection. But it's you're damned if you do, you're damned if you don't. I'm not. What did you do?
So I put a lumbar drain in this patient. I actually had her in the ICU, and I let her blood pressure run in the kind of 140s to 160s, kind of higher than what you would normally do for a type B aortic dissection. And 2 days later, she had a type A dissection.
Yeah.
Retrograde.
That would be the damned if you do, or damned if you don't. Yeah. So I mean, I think that one of the take-home messages is that aortic dissection is a really difficult problem. And that no two patients are exactly the same. And I think that, as we mentioned before, part of the objective of these classification systems is trying to make sense of how we can classify these patients to have a process, a system of thinking to manage them better than we have now.
Yeah. What was difficult with this patient is that the false lumen in the thoracic aorta had thrombosed. It was patent distally.
As you'd expect, by putting a TEVAR in, that wouldn't help the perfusion to the spinal cord, obviously.
And I couldn't fenestrate it endovascularly because there was no flow in the false lumen at baseline to begin with. Just a terrible problem. So going back to malperfusion, so besides dynamic obstruction, there's also static obstruction. So static obstruction is where the dissection extends out into the branch vessels. And it can even lead to thrombosis of those vessels. And so in those situations, you end up having to not just do something at the level of the aorta many times, you have to do something out into those branch vessels to restore flow to them.
Can I change my answer?
Sure.
So, there's a very accomplished interventional radiologist at Michigan, Dr. Williams, who has championed fenestration.
Correct.
And so, I don't know, I think that's my understanding is that's a very advanced skill set to be able to fenestrate a type B dissection. But maybe that would have been in the hands of somebody who can do it well. Maybe that would have been a treatment for that.
Yeah, so she had actually, it was all clot posteriorly in the thoracic aorta, because I had thought about doing that. I've got some examples of some endovascular fenestrations that I've done. And we'll talk about that. I'm going to
change my answer back again.
So for static obstruction, many of these patients, you're going to have to get a wire out into those branch vessels from the true lumen, stent backwards, and then many times you do have to put a thoracic stent graft or some type of bare metal stent in these patients to open up the true lumen as well. They can have both static and dynamic obstruction. One of the things that was always kind of hammered into me by our friend Rich Cambray at MGH was that angiography in this setting can be a trap. And so if you have a patient that you're treating for dissection, all of us are using intravascular ultrasound, and you're trying to decide, does the patient have a malperfusion syndrome? Do they have significant compression of their true lumen? If you put an angiographic catheter in the true lumen and you take your MedRad power injector and you crank it up to pressure limit of 900, and then you shoot an arteriogram, you're going to falsely push open that true lumen while you're taking your pictures, and you're going to lull yourself into a false sense of security that true lumen is open. And so angiography, although it can be useful, really intravascular ultrasound is really the key imaging study in these patients to help decide how compressed that true lumen is and whether the patient has a clinical malperfusion syndrome going on. Since we were just talking about it, so endovascular
Yeah.
fenestration. This is actually from the group at Michigan there. This is from their recent paper of looking at patients that actually came in with a type A dissection, but dissected a DeBakey one that went all the way up and down, and they presented with a malperfusion syndrome in their abdomen. And so in these patients, what typically they'll do is they will leave the type A dissection alone, and they will go ahead and they will perform an endovascular fenestration. And so typically what this involves is figuring out which side the true lumen is on. You'll get a sheath up into the true lumen, and then they actually use a needle that comes out of that sheath to poke through the septum going into the false lumen. In the past, I've used what's termed a pioneer catheter, which is it's a re-entry catheter that's used for peripheral arterial disease by Medtronic. It has a little needle that comes out to the side with an IVUS probe on it, so you can actually rotate the thing around and aim at that septum, aim towards the false lumen, and essentially poke and put a small wire through, and then you can upsize to a stiffer wire. And so what they're typically doing in these situations for endovascular fenestration is they're putting a 16-millimeter balloon, centering it on top of the septum, and then causing a controlled laceration of the septum. And then they'll back their wire out, and then they'll measure pressures in both the true lumen and the false lumen and look with the IVUS. And so in those settings, what they'll see is that ideally, if it's worked, you should see the septum really move to the midline. You should see equalization of pressures between the true lumen and the false lumen. And then again, you can confirm that there's true lumen expansion by intravascular ultrasound. And so this is something that probably is not too far out in the wheelhouse of many vascular surgeons, people with endovascular skills. You can also just take a glide wire and a stiff glide wire or back end of a glide wire and use an angled catheter as long as you can direct towards the septum where it is and poke a hole through it that way. I've done that as well. So different options for patients that present with malperfusion in terms of endovascular fenestration. Also in this setting, they will put so if they have a patient that they've done this balloon fenestration to and the true lumen doesn't expand by IVUS, or if they see that there is not equalization of pressures between the true and the false lumen, then typically what they'll do is they'll expand the true lumen. So they'll put a large bare metal stent. I would imagine that's some type of either venous or a wall stent, something that's large but uncovered, allowing flow going across the visceral segment there to expand their true lumen. The other option is to put a TEVAR in this setting and cover up above and help to expand the true lumen that way. All right, we'll go back in history here. So one of those is open surgical fenestration. So this was really pioneered by Mel Williams at Johns Hopkins. And he had patients that presented with malperfusion syndrome, and the treatment back then was not endovascular. The treatment then was only open surgery. And so in many of these patients, they would take them to the operating room, they would expose the thoracoabdominal aorta, clamp just above the celiac, clamp below the, or just above the bifurcation, and then they would longitudinally open up the aorta. They would split the dissection flap and essentially trim it back, and they would try and if there was a dissection going out into the branch vessels, they would put some stitches and try and reoppose the true lumen there.
I think the original technique was described by Robert Shaw in the 1950s, actually.
Correct.
Yeah.
At the MGH.
At the MGH, yeah.
And they would then put two large strips of felt over the aorta and close that back. And so, and you can also do it, as they're showing here on this third picture, there is a infrarenal graft replacement, hooking everything back up. And so they've actually when he had patients that had an aneurysmal degeneration, they would actually use a dilator and they would trim the aorta back and trim it and essentially close the aorta back over this dilator, getting a more normal aortic diameter. And they followed these patients out for many, many years, and they did not see significant aneurysmal degeneration in these patients by getting them back to a normal aortic diameter. This is a patient that I had that came in when I was in my vascular practice that she had actually, it was kind of a crazy story. She had shown up in an outside hospital with some kind of vague complaints, not really typical chest pain, but all of a sudden was very hypertensive and had become anuric. And so her creatinine was really elevated, not making any urine. And at that point, she got admitted to a medicine service, and they were kind of working her up, thinking that she was probably, and had never really been to a physician before, and so they just figured she was kind of a, chronic hypertensive patient that showed up finally in acute renal failure. And so she actually got a day or two of dialysis. And then she started to complain of some vague complaints in her lower extremities. And then somebody came by and said, hey, maybe she's possibly got a dissection. And so that prompted them, despite her renal insufficiency, to go ahead and get a CT scan. And that prompted them to make the diagnosis of a type B dissection with malperfusion going out into both a dynamic obstruction at the level of the aorta as well as into her renal arteries on both sides. So I actually tried to, so then they shipped her to our hospital. This was 2 days into her dialysis course. And I tried to perform an endovascular fenestration. I could not, for whatever reason, get across. And so at that point, I've got this lady that, normal appearing kidneys by CT in terms of length and width, and acute renal failure. And so I actually took her and did this operation, did a midline operation, exposed her infrarenal aorta, clamped above her renals, kind of just below the SMA, and performed a longitudinal aortotomy, was able to cut out the septum, actually cut it all the way back up to the clamp there, and put a couple stitches in and reapproximated the adventitia going in, or the intima going into her renal arteries, and then ran this big felt strip over the top. And literally we took the clamp off and she started making urine on the table.
Wow.
And 4 days later was completely off of dialysis with a normal creatinine.
Wow.
I ended up following her out for several years, and her kidney function remains. So in settings, there is still a role for open surgical fenestration.
Wow. That's a great
Always,
that's a great outcome.
Always remember the successes.
Yeah.
Try and bury the bad ones. So why don't we, let's take a break here and let's answer some questions from our audience. Could we roll back up to the top there on the screen, please? All right.
I think the other top. There you go. Yeah, there we go.
There's some questions about simulation and training.
The first one. Okay, Marvin, I'll ask the question since
Sure.
type B aortic dissection complicated by acute hemothorax. Should I go surgically in the absence of an endovascular program? What are the tips and tricks for a young cardiovascular surgeon?
Yep. So, I think it obviously it depends upon your institution, but, if you have the ability to go to a hybrid room, that is kind of the first step. So if you made the decision that the patient has a complicated type B aortic dissection, they need an immediate or emergent intervention, leave all your options open. And so typically in these patients, we will take them to a hybrid suite where we can perform both open and endovascular or hybrid options for that patient. And so I think that's probably the first decision point is, do you need to go? And then the second is, where do you go? And hybrid facilities definitely leave your options open. And so that's the first kind of thing that I would do. I think it really depends upon the stability of the patient. I can probably get into the femoral vessels and put a thoracic stent graft in faster than I can position the patient, do a thoracotomy, and get a clamp above and below. Depends. So I think a lot of it really depends upon the patient's anatomy and whether you think that they can get a good result with a type B dissection with a stent graft. Can you seal that entry tear? I think that's definitely, at least in my bag of tricks, that's kind of the first thing that I would go to. I'd love to get your opinion.
Yeah, so I think that, there is a spectrum, I think, too. I think that
Sure.
Not uncommonly, patients who have a type B dissection will get a pleural effusion. Mm-hmm. And just because they have a pleural effusion doesn't mean that they have ruptured.
Right.
Oftentimes, just with the pressure, that's in the mediastinum, you'll do a thoracentesis or put a chest tube in, and it's not blood, or it's sort of blood tinged fluid, sort of a cheesecloth kind of fluid. I think certainly if it's blood, I mean that is an emergency, and I think you have to. That would be
especially if they have some hemodynamic instability at any time associated with that.
So I think in this day and age that endovascular therapy for that is definitely the first choice. If not available, as framed in the question, I do think that would be an open surgical operation.
Sure.
That carries with it significant morbidity and mortality. It's operating on an acute type B dissection is different from operating on a coarct or operating on an aneurysm.
Right.
I would say that to do that, you go in and try to fix the problem. You look for where the rupture is, if you can find it, get proximal and distal control, and
go from there.
Go from there.
How would you manage that from an open standpoint? Do you try and put felt in your anastomoses, in between the layers, on the outside layers, both?
Yeah, so that speaks to the second question. How do you sew dissected aorta? I mean, as we all know who've done it, the tissue is very fragile. The principle of operating on a dissection, endovascularly or open surgery, is you want to reestablish the wall of the aorta. So you want to close the false lumen. You want to close the entry tear and redirect flow through the true lumen. So if you're dealing with a type B dissection and you know where the entry tear is, going in and resecting that entry tear would be important, and you could do that with a graft. And then to obliterate the false lumen distally, what I like to do is I'll put a layer of felt inside the false lumen and take a fine suture, a 5/0 or 6/0, and sew that sandwich together, the intima, the felt, the median, the adventitia together, and then sew that to the graft.
Any bioglue in the middle of that, or have you gotten away from that?
So I've gotten away from bioglue. I mean, bioglue was, for a while, I, like many of us, thought that bioglue was the greatest invention since sliced bread. You take bioglue, you put bioglue on the tissue, and it stiffens it up. Doesn't make it hard, but it makes the aortic wall kind of like skin, so you can hold it with a forceps. You can put stitches in it, and it will glue the true and the false lumen. I mean, it'll glue the layers to obliterate the false lumen. But I have over the years noticed that it's associated with pseudoaneurysms, and the solution for today can create problems for tomorrow. So I've gotten away from using bioglue for type A, type B dissections. So
in these settings, obviously you would probably avoid a lumbar drain. You don't have the luxury of doing that in an emergent operation.
Right.
Left arterial femoral artery bypass in these patients?
So it depends on where I'd be able to, if I had the chance to put a clamp above it, whether it's up in the, if I can get proximal to the left subclavian artery, or if there's normal aorta distal to the left subclavian artery, I would use left heart bypass. If not, I'd use full bypass.
Okay, great. Excellent. Let's see, we've got some other questions kind of about simulation. We'll kind of skip those.
Yeah, I don't know of any, to my knowledge, I don't know of any high fidelity simulator for aortic dissection. Are you familiar with any?
Take a couple sheets of tissue paper,
wet
them, and then try and sew them together, I guess.
That's all. Is that high fidelity or low fidelity?
That's all right. Bad problem.
Yeah.
All right.
Good questions. Thanks,
yeah,
audience.
All right, so let's go now into how are we going to manage these patients. So try and look at the data a little bit. So the first one here is natural history of medically managed type B aortic dissection. So at the MGH they looked at, in 99 through 2011, they looked at patients that presented with acute type B aortic dissection less than 14 days from their symptoms, who had no evidence of malperfusion, and the initial plan of these patients was medical therapy alone. And so what their goal of this study was to look at the failure of medical medical therapy, looked at patients that died, and then if they had any complications that required intervention after making the decision that they were going to manage these patients medically. So they had 826 patients initially came in with an acute aortic syndrome. 55% of those were type A's and were excluded, so it's usually kind of 2/3, 1/3 is the usual breakup between type B, type A.
Type A, 2/3.
Type A, 2/3, type B, 1/3. And so of these patients, they had about 9–10% who had a complicated type B aortic dissection. Those were treated initially surgically, and so those were excluded as well. So that left them with kind of 298 patients with an acute type B aortic dissection who they were going to manage medically, and they followed these patients out.
So as a rule of thumb, complicated type B dissection makes up about 15 to 20% of all type B dissections.
Right. Depends how you define complicated as well.
Depends how you define it, yeah.
So if
you can make that number higher or lower.
Yeah, if you add in the patients that have, hard to control hypertension or continued pain, your numbers are going to go up.
So in the flip side is if you just have malperfusion syndrome or rupture, that number is significantly lower.
Right.
Yeah.
So in this patient population, they had a mean follow-up of about 4.3 years. They actually had failure of medical therapy in 58% of these patients. So 30% of them required some type of aorta-related reintervention, and in that time period, 38% of patients died.
It goes back to what we were talking about before. It is not a benign
disease.
I mean, it is a serious disease.
Correct. All right. So probably the best known study that's out there is actually from 2003 to 2005 when they collected patients. And so this was the INSTEAD trial and then followed up at the 5-year mark by the INSTEAD XL trial. And so we'll that's probably the best randomized study that's out there for best medical therapy or best medical therapy plus TEVAR for patients that have uncomplicated subacute type B aortic dissection. And so we'll dive into this study a little bit more and look at some of the data. So this was again uncomplicated type B aortic dissection. So these are patients that presented between 2 weeks and 52 weeks from their initial onset. The vast majority of these patients were kind of 10 to 12 weeks at the time of their initial dissection. This was 7 European centers, and the patients were collected between 2003 and 2005, and they were followed for about 5 years. And they were published in 2 different initial publications, one at the 2-year mark and then one at the 5-year mark.
Yeah.
And so when they finally had all the patients randomized, there was 140 patients which they randomized again to best medical therapy or best medical therapy plus TEVAR. And at the 2-year mark, there was really no statistical difference between the two in regards to mortality or aortic-related mortality, although there was a trend of the curves diverging. And so they followed these patients out to 5 years, and they published the 5-year results.
So at 2 years, I thought actually there was a statistically not different, but actually favored optimal medical therapy.
Correct.
Yeah. But what was compelling about it was that if you looked at the remodeling, if you looked at the size of the aorta, you looked at the size of the true lumen, you looked at the size of the false lumen, it was significantly better with TEVAR plus optimal medical therapy.
It was 90%, at least their definition of remodeling. So again, if you just look at the segment of the thoracic aorta where the TEVAR is, many of those patients are going to remodel there, and that's, I believe, their definition of what they used is remodeling, positive or aortic remodeling.
But if you looked at death and aortic-related death, it was not statistically different. And I think that kind of, I remember when this study was published, and it kind of took the wind out of the sails of TEVAR for type B dissection.
Right. And then they presented the 5-year data, and it kind of swung the other way. The winds came back. And so this is from that paper. You can see there causes of death since randomization. And so the group on the left there is optimal medical therapy, and then on the right side there is optimal medical therapy plus TEVAR. And this is their consecutive patients. And so what they found is that TEVAR initially, definitely any type of procedure where you're going to have risks and complications, you're going to have an upfront cost to that. And so that's where they saw more problems. They had one type A retrograde dissection. They had 3 patients that ruptured. And then when they followed those patients out to about a year, they had a couple that had a heart attack, somebody died of cancer, somebody had died of a pneumonia. So about 3 ruptures and 1 type A dissection in that TEVAR plus optimal medical therapy group. In the optimal medical therapy group, they had 1 patient died of a malperfusion syndrome, 1 patient died of a rupture, and then things were kind of stable. And then a year came along, and then you can see there on the left graph there, you can see all of the patients that had difficulties and problems with the aorta beyond a year, and none in the group that had optimal medical therapy plus TEVAR.
It's very compelling. So I'm not a statistician, but so that statistical methodology they use is landmarking, and if you kind of take away the 2 years that occurred before that and look moving forward, I mean it is really striking. Now, they say that it wasn't powered to statistically show that, but those, to me, that graph, the red being TEVAR plus optimal medical therapy as opposed to the blue being optimal medical therapy, I think it is really a striking and compelling argument for TEVAR plus optimal medical therapy. And I think it also piggybacks well with the graph that you showed from the MGH natural history studies, is that as time goes on, the risk of problems from medically managed type B dissections continues to grow. So, and also too, I think, and this was relatively early in the experience with, not experience with TEVAR, but the technologies for using endovascular stent grafts for type B dissections. And I think we've learned a lot more since this, though you could argue that maybe the early intervention-related morbidity and mortality may be less now.
Right. So I think one of the things that we struggle a little bit with is, when do you treat these patients if you decided that, based on the INSTEAD XL data, other data that, these patients are going to benefit from TEVAR, when do you treat them? I think obviously this study, they excluded patients within the first 2 weeks. So I think if you've got a fresh aortic dissection, type B aortic dissection without malperfusion, uncomplicated, definitely initial best medical therapy is the best route for these patients. If you treat them acutely, the risk is the higher rate of type A dissection, retrograde dissection, if you're treating a septum that is extremely fragile, an aorta that's very fragile. And so in these patients, we'll typically manage them initially medically and have serial imaging. So we'll get their initial scan, we'll get one at 48 hours, we usually get one at discharge in these patients, and it may take several days or longer to get their blood pressure under control, depending upon how bad their hypertension is. And then we usually will get one at a month. Has that been your typical kind of imaging
Yeah, so I
protocol?
get one at admission, check one in 48 hours, check one at discharge, check one in a month,
Okay.
check one at 6 months.
6 months.
Yeah.
And then yearly thereafter.
And then yearly thereafter, unless there's a change.
Right.
I think that these, as we used to say, dissections are the gift that keep on giving. And I think that you can and should anticipate that there will be changes in many of these patients. And the closer you look, the more you'll see.
Right. In terms of the medical management of these patients, Tom, how are you ensuring that these patients are getting adequate medical therapy? Are you having them see a nephrologist? Are you having them see a cardiologist? Who are you typically sending them to? Do you have them just go back and see their family physician? Who is managing these patients that have difficult to control blood pressure? Are you managing that?
Yeah. So all politics is local, as Tip O'Neill said, and I think when I was in Boston, the practice was different. We had some cardiologists whose practice were very focused on managing patients with aortic disease, and they were superb in managing aggressively and compulsively and comprehensively their blood pressure. Mm-hmm. And so they would be the ones who would care for these patients in addition to their local cardiologist, in addition to their local primary care physicians. down here that many of the primary care doctors or local cardiologists will take over that management. But I think it's very important to communicate to whoever is going to manage them that these aren't just patients with hypertension. These are patients who need to be very aggressively managed.
Right. Great. All right, so I had a couple just quick cases here we can talk about. I think we've got a few minutes left here. So the first one, so this was a 70-year-old female who presented with chest pain, interscapular pain, hypertensive urgency to an outside hospital. Initially managed medically, was discharged 5 days later with her blood pressure under control and her chest pain improved. She had a CT scan that demonstrated that she had a type B aortic dissection. She came back a week later with recurrent chest pain, again elevated blood pressure and enlarging false lumen by imaging, and she was subsequently transferred to our hospital. And so her ascending aorta, 41 millimeters, a little dilated. You can see the measurements there. Everywhere else, really not too bad on her initial imaging. 32 millimeter, 33 millimeter true and false lumens. So that's definitely somebody, you know, in the absence of worsening pain, in the absence of difficult to control high blood pressure, we would manage that patient medically. Gets the second scan 10 days later during this readmission, and now her total aortic diameter is now increased to 43 millimeters from 32. So really 11 millimeter increase in just a short time period. And now her true lumen is also decreased significantly. So much more flow is now being shifted over into the false lumen. And you can kind of see, I don't have a great picture here of her entry tear, but again, it's kind of in the proximal descending thoracic aorta. So her type B is really kind of limited to her descending thoracic aorta. You can see at the level of the hiatus there, basically the dissection goes away.
Sort of 3B.
3B, yeah. Correct. Or 3A, I guess. 3A.
Excuse me, 3A, yeah. I have my number right, my letters wrong. Yeah, excuse me, 3A, yes, exactly.
Or I guess she would actually be a B, that would be 3, 5.
Is it 3 or 4? Is it how far from the subclavian?
B4, comma 5 in the new classification system. We got to learn it ourselves.
Exactly.
Get a cheat sheet out here. All right. So in this patient, could this have been an IMH or a PAU that was kind of thrombosed? Hard to say. She had very small iliac access, 4 and 5 millimeter vessels, but now with an enlarging aorta, difficult to control high blood pressure and chest pain again, and with a readmission, the plan was to go ahead and treat her as, you know, she's about 2 weeks or so out now from her initial dissection, so the plan was to treat her with TEVAR. She's stable. We did have her on an ESMO drip when she came in, got her blood pressure under control. In this setting, because I was going to treat a long segment of her aorta and we had the luxury of time, we went ahead and put a lumbar CSF drain in, put a right radial A line in case I needed to cover the left subclavian. General anesthesia, and because of her small iliacs, we had to do an iliac conduit, so that was done through a small retroperitoneal incision. Put a 10 millimeter graft on there. So in this setting, we put a Medtronic Valiant graft in her. So you can see we've got a double curve Lunderquist wire there. We're now getting our device into position. That's typically when I'll take the first picture, or actually in this setting, I guess I took a picture beforehand with the device not into position yet. In this setting, what I've done lately, if I have a patient, and this was probably about 10 years ago when I did this case, but this is in these settings when I need to kind of land the thing perfectly, we've taken some of the skills that we've learned in transcatheter aortic valve replacement, TEVAR, and rapid ventricular pacing, and so many of these patients these days for TEVAR will go ahead and we'll put a pacer in them that we can rapidly pace them during deployment that will mitigate some of the movement of the thoracic stent graft. And again, we've extended this with 2 different pieces. And here's her follow-up scan at a month. Fortunately, no evidence of stroke. We actually landed the thing partially across her subclavian. I did not have to cover her subclavian. We landed above the celiac there, and her aorta looked pretty good at a month. and it's remodeled and looking pretty good at a year.
So Marvin, in a case like this, if you just a few millimeters more, and if you had planned to cover her subclavian, would you have prospectively done a carotid subclavian?
You know, I would.
bypass?
You know, if I have a patient that I'm electively planning their TEVAR operation, the worst complication, as we've all seen, is patients that are paraplegic.
Yeah.
And anything you can do to mitigate that risk, in my thought process, anything I can do to mitigate that, I will try and do. I'll look at their iliac access. I'm looking at their hypogastric arteries, deciding which side I need to go on, also which side is true lumen, which is false lumen, but really making sure that we're getting antegrade flow going into the hypogastrics during the operation, at least one of the hypogastrics. And then anything I can do to supercharge their vertebral artery, such as a carotid subclavian bypass first. Nowadays we do have branch thoracic grafts. They're not ready for prime time, but we're hoping in the next year, at least the first trial should be out with some results and hopefully FDA approval of the Gore TBE device. But we're hopeful that you know, that can also play into saving the subclavian artery if you have to cover it at that time of operation. But I would not hesitate in this setting to go ahead and do a carotid subclavian bypass first.
Because I think for those of you watching, it's not just the perfusion to the arm that the subclavian is important for. It's the vertebrals that provide circulation, you know, posterior circulation, particularly if it's a dominant vertebral, but also, as you nicely pointed out, the role of the vertebral and the subclavian arteries for the spinal cord perfusion. So all of those are very good reasons to be mindful of the subclavian artery. In an emergency, you
do what
really,
you have to do.
You do what you have to do. Yeah.
In these settings, especially these days with our excellent quality CT scans and sub-millimeter fine cuts, I'll also go and look at the intercostals and see, especially down at the level just above the celiac in that kind of T8 to T12 area, are there intercostals that I would really love to save that look really big? In those settings, I will plan on landing my TEVAR short so that I can preserve that. Even if it means to have an endo leak. Ideally, we would not like to have that, but I'd also, more importantly, not like to have a patient that's paraplegic.
Do you have much experience using the petticoat of putting in
uncovered stents distally?
Distally?
Yeah, so fortunately in my previous vascular practice I was fortunate enough to be part of Cook's stable trial. So that's essentially a covered thoracic stent graft, their TX2 graft up above, and it has an uncovered stent graft, uncovered stent that then extends all the way into that graft, all the way down through the visceral segment into the aortic bifurcation. And so that device I think comes in a 46 and a 36 diameter, kind of two different diameters. It has really big interstices. It's really kind of flexible. And the patients, I think I put maybe 3 patients in that trial, all 3 of them had just amazing aortic remodeling and completely thrombosed their false lumen.
Wow.
So I'm a big fan of that if you have a patient, especially if they've got malperfusion syndrome and you really need to establish, get rid of a dynamic obstruction. I think it's definitely a great option for patients. I think we've got a couple minutes here for a second case and then we'll cut it short. So this is a 68-year-old female, again, severe chest pain to an outside hospital. She's steroid dependent, rheumatoid arthritis, end-stage renal disease on hemodialysis, so not very healthy despite being 68. Her CT just looks horrible. She's got a very diseased aorta throughout the whole entire thing. There's multiple areas of IMH, PAU, and this type B. And she also has a left-sided hemothorax coming in with chest pain. Got transferred by helicopter to our hospital, so really needs something done emergently. No time for a CSF drain. And so you can see all the hematoma around her mediastinum. We can see maybe her trachea shifted a little bit over there, but definitely kind of an ugly-looking descending thoracic aorta. As we follow that down, really ugly. You can see distally, proximally it looked like it was thrombosed, and then as you get distally here you can see that there starts to be some flow in kind of the mid-descending thoracic aorta and a lumen there, which is the false lumen, and then we start to see that fluid collection over there.
Let's say a double black diamond situation,
Yeah.
to say the least.
Yeah, so, we talked a little bit earlier about the patient that has the effusion. And so say, for instance, you tap this or you put a chest tube in this in the operating room and it's not really clear, it's not frank blood, but it's that serosanguinous kind of, how do you treat that one? It's pretty obvious if it's blood, it's pretty obvious if it's serous fluid, but if it's somewhere in between, your thoughts?
Yeah, that would be somebody who I would have a very low threshold for
doing something.
For doing something about it.
Gotcha. Okay. But ugly looking aorta, real
and
shaggy
the
aorta.
mediastinum looks very
Hostile.
worrisome.
Right. And so then we proceed down through the visceral segment here, areas of heavy calcium, really ugly looking laminated thrombus in the posterior aorta there. And of course she's got kind of a napkin ring, aortic bifurcation, heavily calcified iliacs, heavily calcified femorals, your typical patient on dialysis. So in this patient, we felt that we needed to obviously do something. If I take a look up at her coronal sections here, you can see that the dissection goes all the way to the level of the left subclavian artery.
Yeah.
So in this setting, do you do an emergent carotid subclavian bypass first? Do you put a TEVAR in her and then see what's going on? If she has any spinal cord ischemia or any arm ischemia, then do it afterwards. How would you manage that, Tom?
Yeah, I'm not sure that if there's a right answer to this. I don't know what it is. I think I would probably go in and do the TEVAR first and then do carotid subclavian bypass second if needed.
Gotcha.
How about you? What would you do?
That's what I did.
Yeah.
Yep. So again,
we're either both right or we're both wrong.
That's right. And so you can see the two long pieces of a thoracic stent graft here kind of partially covered her left subclavian. You can see down on the screen on the right there, you can see it's kind of dilated there at the visceral segment a bit. You can see it outpouching some. Again, I guess we didn't really touch on this at all about TEVAR and dissections, is really do not balloon unless you absolutely have to. And I would stay away from ballooning at either the proximal or the distal landing zones for sure.
And sizing too, right? You want to be more truth in sizing?
Correct. Really 10 to 15% oversizing. Basically you would use the either the transverse arch or the ascending aorta, anything that's relatively normal that does not involve the dissection as your kind of starting point of what a diameter should be, and only go 10 to 15% oversizing and try not to balloon if you don't have to.
So proximally, how big is too big for your landing zone? So in your arch. And if you have some hematoma that extends into the arch, make you nervous about landing your stent graft? And
very, very nervous.
What would be your options for that?
Yeah, so the stent grafts go up to about 46 millimeters. So ideally, should be no more than 42 millimeters. If you want to be a little oversized, then maybe a 40 millimeter aorta. That's probably, I would bet. Approximately, it also your length of your seal zone. So obviously the longer the better, but at a minimum of kind of 2 to 2.5, some people say 3 centimeters of kind of normal aorta to seal into if you can. It obviously all depends upon what you're given, the cards you're dealt. But ideally, you would like to not hang a stent graft on a 1 centimeter seal zone for a type B dissection. You're going to end up with a problem in that patient.
Another option is doing an open repair or doing a frozen elephant trunk. Yeah.
Correct.
If you have a dilated dilated arch, you want to have a number of clubs in your bag depending upon where the ball lies.
Correct. And so fortunately, despite this horrible shaggy aorta, we got a pretty good result a year later.
That's a great result, yeah.
And it pushed everything out, and I think we're done. All right. I would like to thank everyone for joining us this evening. Tom, thank you so much. Always a great discussion with you. We're going to continue this series for the aortic talks. We'll consider some of the other nuances of aortic dissection down the road here, and we'll talk about probably AAA next, I would imagine.
This is great. Thanks, Marvin. Thanks for leading a great discussion. And thanks to the audience for your participation. Looking forward to seeing you next time.
Thank you, everyone. Have a great evening.